It's loud. Okay. So first, let's do a land acknowledgement because I would like to acknowledge that we operate on the ancestral and unceded territory on the Coast Salish people, including the territory of the Musqueam, Squamish, and Tsleil-Waututh Nation. We recognize their ongoing and contribution to the health and well-being of their community. I also want to express my respect and gratitude for the opportunity to live, work, and serve on this land because of them. It is crucial that we honor and support their rights, cultures, and history of Indigenous people as we work towards reconciliation and improving healthcare services for all of us. So first of all, I would like to acknowledge, let's give a warm welcome to Dr. Mark A. Clements. Welcome to Canada. And Dr. Clements is recognized as an expert in diabetes data analytics with broad patient care and clinical research experience. Dr. Clements trained as a clinical researcher at Children's Mercy Hospital, while he has applied his skills to clinical trials of new diabetes treatments, clinical trials of treatment designed to prevent type 1 diabetes, intervention, development, research, and risk prediction, and health outcome research in type 1 diabetes. He's also the associate professor at the University of Missouri, Kansas City. He serves as pediatric chair of the T1D Exchange Clinical Registry from 2016 and 2019, and currently serves as a data science co-lead for the T1D Exchange Quality Improvement Collaborative. Dr. Clements has a particular interest in the application of predictive analytics, real-time data listening, and digital health therapeutics to positively transform diabetes care. So then now the floor is all yours, Dr. Clements. I'm going to pass it to you.
Thank you so much.
I'm going to stop share.
I will share my screen.
Yeah. Let me see.
Okay. You can see that okay?
Yep.
Okay, so please do let me know if my volume's not coming through for those who are online. But it's a real pleasure to be here with you today. I want to thank Shazan for inviting me and my colleague Dominique to join for these 2 days. There are a great many things that I could talk to you all about today. We're just going to have a little conversation about how to leverage electronic health record data to quality improve diabetes care. And I'm just going to share a few small thoughts with you. So this isn't overly ambitious and hopefully nothing that is earth-shattering, but maybe will help provide a frame of reference for how I think about it and some of my colleagues think about it. I do have some disclosures. They're right here. I don't plan to cross over any of them in a negative way today. So first, where am I coming from? I come from a children's hospital in Kansas City, Children's Mercy. We are a Kansas City-based nonprofit, over 8,400 employees. Our diabetes center has 30 physicians. We provide care for 2,700 youth and young adults with type 1 diabetes. And you can see some of the stats about our hospital volumes just for comparison to BC Children's. And where are we located? We're located just close to the geographic center of the United States, and we straddle state line. So we are the Department of Pediatrics for the University of Missouri in Kansas City, and also the Department of Pediatrics for the University of Kansas Medical Center. And we have a big, beautiful new research institute, and you can't see it very well in the picture below, but it faces downtown Kansas City, and when the lights are on at night, it looks like Sanger DNA sequencing for those who are genomics aficionados. So objectives today, first, just to provide an example of a successful project using data from electronic health records and REDCAP to improve pediatric diabetes care, to discuss a little bit how we might enable learning health projects through improved data access and quality, and how to think through the silos of research and quality improvement, and then finally to identify opportunities to realize the benefits of our of your new electronic health record system, which we call CERNER, you call CST, it's the same, to better support learning health systems and improve care in the PHSA. So these are the topics that I was requested to talk about, so I'll just share a few thoughts related to them. So let's talk first about CERNER and REDCAP and what we've done at the Children's Mercy Diabetes Center. Over a decade ago, we were on a journey. We were about 4 years into our journey. Did my video stop?
Yeah.
Oh, let's try it again.
We can see
back. Okay. So over a decade ago, we were on a journey for implementing CERNER. We first implemented CERNER in 2008, but of course it takes multiple years to implement a new electronic health record system. One of the functions that CERNER offers is CERNER web forms. And CERNER web forms can be used to get patient-reported outcomes and experience measures. The only problem was that in the US, we were under this new federal mandate for meaningful use. And that meant that every health system that was implementing new electronic health records that met the very detailed requirements that the federal government had imposed on us all had about I would say 45 or more different initiatives that they had to implement as quickly as possible. And as our CMIO told me, each one of those had 45 sub-initiatives under it. And so if I wanted to get a new patient-reported outcome survey into the medical record, I should get on a list and wait 18 months. And I found that unpalatable. So being who I am, I came back to her weeks later and said, you know, in research, we do a lot of work with REDCAP, and I think I could actually bend REDCAP to my will in clinical care and to allow us to do some of the patient-reported outcomes collection for clinical care that we need. Will you allow me to do this? The first answer was no. The second answer was no. The third answer was no. And eventually she relented and said yes. So just persistence pays off. And what ultimately changed the equation for her was when I came back and said, I have a $1.3 million grant and I have to do this. And it requires that I have access to this. So that changed the answer. So, what we do is now our informatics program pulls identifying information on patients from the electronic health record into REDCap. So when a survey is sent to a patient, it's not sent as an unidentified survey. It's actually linked to their identifiers. We actually are able to take the results of that REDCap survey and send an SMS alert in real time to the correct care providers about the results of that. So if we do a depression screen in REDCap at the point of entry into the clinic for a diabetes patient, then at the moment that that survey comes back, if they screen positive for depressive symptoms, the social worker gets an SMS message. I get an SMS message. The SMS message is protected because it has no protected health information. It tells me that the patient in room 7 right now had a positive screen. So now I can go in CERNER and see who that is on my schedule. And then we have access to the results both as PDF reports out of REDCap in CERNER, also as discrete data in CERNER results review, and then we are able to extract those for population health reports, for clinical operations, and available for research. So this is, sort of what it looks like to do some of our psychosocial and behavioral screening. We have created intelligent logic in REDCap long before some more recent functionality came out in REDCap that allows us to identify trigger points for delivering these surveys. So the base case is that once every 11 months, and we chose 11 months because they don't always have their visits at exactly 4-month intervals, they will get screened. And you can see that we pester them a little bit in the week before, and a lot of that is scientifically based. We tested how frequently and how many times we could do it before we started getting complaints. And seriously,
sort of like children with their parents.
Yeah. And then they get a text or an email, to complete this. As I mentioned, the results interface into CERNER in near real time. Within 15 minutes, the results are there, usually within 5 minutes. And then we get the notifications to the provider and social work. These are the things that we're doing right now. So we went from 0 patient-reported outcomes surveys embedded in our clinical care flow processes to all of these without overwhelming the families with burden and without overwhelming the providers with burden. And the way we do it is we track, again, if you had a positive screen at your last visit, we're going to screen you again at this visit. If your screen was negative the last time, you're not going to get it again for 11 months. If we screened you the last time for anxiety and depression, then we're probably not going to screen you for diabetes distress today. We're going to wait until the next visit when you don't have that burden to fill out questions. We've identified that families can tolerate questionnaires that take up about 8 minutes of their time. If we exceed 8 minutes, we start to get complaints. So again, we sort of took a very data-driven approach to how we do this. And so we think about those 8 minutes as the golden time for us to gather all the supplemental information we can that will help us improve their care. But we try very hard not to exceed those 8 minutes. You can also see that we have what's called a rotating tool. So we have test questions. Every quarter, we introduce test questions into our patient population that help us to understand and gain new insights into how these PRO measures might play with our families when they interface with them and how our providers might use them. And then we survey the providers and ask if they found it valuable. So for instance, we've rotated in fear of hypoglycemia surveys, a survey that assesses knowledge about healthy eating and nutrition and diabetes, et cetera, what mobile apps they're using. The advantages of this approach for us was that we could move at the speed of light. We didn't have long development cycles. The entire change control was managed within the diabetes center. We didn't have to go through long cycles of institutional committee change control. And only when we decide to implement something permanently do we then send it through committee to get all the change control approvals that we need. But under the quality improvement umbrella, we can cycle new surveys in without going through all those permissions. And then we added intelligent functions like the triggered SMS messages, which REDCAP now has natively, but it didn't at the time that we started. Changing times for resurvey based on the patient's own data, score triggered resurveys, or we go from like PHQ4 to PHQ9 based on a trigger. And then we now embed educational materials as an automated response. So if you meet the threshold for diabetes distress, now you get an automatic invitation to a set of resources from you.
That invitation, is it an email? Is it also through SMS?
So the way we're doing it right now is they're getting it through SMS. The way we're going to be doing it is we have designed our own hospital-based mobile app. And as we get more and more families using that mobile app, we're actually going to give them a push notification inviting them into these resources, which are now embedded in a digital care pathway. So, and this is actually a part of an NIH-funded study I'm doing with a psychologist colleague of mine. We've been working together for many years, so we're doing a clinical trial on it. And uniquely, we are assessing, so sometimes we're assessing the children, but as a pediatrician, I believe that we also have a responsibility to provide care to the parents who are the biggest influence on the health of their children. And diabetes distress affects parents as much as it affects kids. And so we have designed a program that treats both parent and child diabetes distress. And I think it's really unique in the field. I'm not aware of any other diabetes centers that are really delivering treatment programs for parents. So it's something that I think is sort of a new frontier. We've changed it over time, right? We began with iPads in every intake room, and we would, follow the iPad with them into the room. They finished the surveys, which helped their perception of wait times because they were doing something while they were waiting. Then the pandemic happened, so we changed, and now it happens with an SMS link to families. which means we've also had to manage certain things in the process, like we don't want to deliver any questions related to suicidality until they are at the point of care with us. So we actually remove that question when we send the SMS, because if we don't have the capability to respond to it immediately, we don't want it sitting out there for 7 days with nobody responding to it, right? And then we do actually have a mechanism now, because some questions we really want the teenager to fill out themselves. And so we do ask the parents for permission for this teen's cell phone number to send certain questions directly to their phone. Some of these are increasingly available through a portal online through CERNER web forms. So we kind of have like REDCAP, but now we use CERNER web forms to get to that. So using CERNER web forms does not limit our ability to cycle in new test questions, because the base surveys are still happening in REDCAP. It's just that some of the permanent baked-in functions are in CERNER web forms, and then CERNER web forms links out to our REDCAP, where there's a transition. And you can see it's not just in diabetes, we're doing it across multiple disciplines and for multiple reasons. We've probably got about 30 or 40 of these on the website. So it looks like this. You know, we can make it prettier. We haven't worked too hard to make it prettier, but all of this will be filled in automatically when they get the survey link. And then the room number, if they're filling it in clinic, will be filled in by the care assistant when they send them the survey link. So it'll be automatically there for them. And that's how we get that SMS notification that the patient in room 7 has screened positive. We can deliver them in English and Spanish today. We're hoping to expand the number of languages. You can see we can introduce information to them. So when we want to share some new important care process or scheduling process, that can actually be delivered to them in line with these. And then, you know, we sort of followed a quality improvement process for this. So we created a key driver diagram. We set up a quality improvement charter. We said, what is it that will help us assure that we're screening patients according to the standards of care at a high level, and referring them appropriately for care, and use that to guide our work. We mapped out our clinic workflow processes, so swim lane diagrams, the whole bit, and then use that to understand, you know, at what points do we have bottlenecks in this process, at what points can the process fail, et cetera. And then, you know, today we again use a system where we have a PHQ-4 score, and then that triggers a PHQ-9 that flags positive. Based on some recent data we've collected, we're thinking about changing that. We might just be doing the PHQ-9 or the PHQ-8 remotely to avoid that suicidality question, just because we've done some analysis of all the pediatric depressive symptom screeners, and we've identified some issues with sensitivity and specificity using the method that we're using today. So we're working that into our workflows going forward. And then this came from a publication we had, I think, in pediatric diabetes, and you can see kind of what our journey looked like during the initial phases of this, to really go from 0 in the first weeks to 100% in the very early cycles, where we're just doing small tests of change, you know, just 8 patients in one clinic day, et cetera. But then as we started to expand across all of our clinics, you can see the numbers drop, and then they start to rise again. And they rose to a pretty high level, and we continue to try to make sure that we conduct these at a very high level. So that's just one example. We also have, as I mentioned, programs for screening and referring for diabetes distress. We have a social barriers to health screen to refer program. Very proud of that one, because we actually have a partnership with a company formerly called Aunt Bertha, now called findhelp.org, that allows us to create a closed loop with community health or community advocacy organizations. So when a family endorses a need, like they can't make their rent payment or their utilities, or they have no transportation, we can automatically refer them to the appropriate community organization in their zip code. That community organization now tracks whether they've offered the service, whether the family has accepted and taken advantage of the service, and then they send information back into our medical record to let us know whether it happened. So we get to see the whole loop. So I'm going to switch gears here and talk about data access for learning health projects. Just a few principles that I follow. One is that EMRs are not designed to do everything we could possibly want them to do. For us, they're really designed for data entry and storage and supporting care processes at the bedside with what I consider to be often rudimentary visualizations. They get the job done, but there's probably not as much human factors behind them as perhaps there could be. And therefore, we must acknowledge that we have to get data out for other applications from the medical record. One question that I had that we don't have to answer in line here, but what do you use today, or what will you be using to get data out of CERNER? We used to use business objects to get data out, and it was horrible. Just because a third-party vendor connected to complex electronic health record data, it was very difficult mapping. We had a lot of issues with trust in the data reports. Now we use CERNER's Healthy Intent product. It's much, much better. You have to understand that whenever you customize CERNER, then your informatics team has to map those new data features to Healthy Intent before they become available for reporting. And so that hard work has to be done. It's especially true for discrete elements from clinical documentation. So we use CERNER's dynamic documentation tool. CERNER dynamic documentation is different than the Power chart. I think, are you guys using a Power chart?
We decided to use iView, so let's see how that goes.
Okay, well,
Yeah.
however you do it, you have to ask yourself, can I get the discrete elements from this section of CERNER, whatever function you're using, out in a report? And so it's just very important to understand what that timeline will be on the back end. Once you're getting data in, how long is it going to take me to map all the elements and be able to get the data back out? And then you have to examine data governance policies, what's restricting appropriate access to data, and how can you overcome those restrictions to get the job done that you need to accomplish. And we had that conversation this morning that there may be some barriers to customizing your CST experience that might call for having a group of stakeholder centers come together, decide what's really important, and then lobby for the appropriate kinds of customization. So what do we need from data to support learning health systems? Well, the first thing is we need accuracy and trust, right? I told you those business objects reports, they were a no-go for us. All kinds of problems. Even recently, we're a very mature organization right now, but we're constantly hiring new people. My data science team in my lab was building some reports for a collaborative research project. And oops, we realized that we had a little bit of mission drift, and they started pulling the diagnosis date for diabetes from a new place. And the leadership of the team didn't notice they were pulling it from a new place. And they were asking questions about why were 20% or 25% of these patients not having an A1C at diagnosis the way we expected it. And as I dug into the conversation during one of our lab meetings, I said, because you guys are pulling the diagnosis from a place in CERNER you shouldn't be pulling it from. So we need to change that, get back to the original process as it was intended, look back at the documentation, and it will fix the problem. And then data completeness. So it's great if you create data standards, but if you can't get your clinicians and your nurses and your other allied health staff to actually enter the data, then when you get the data out, it's going to be super confusing, and people are going to say, well, what are we going to do with data on 43% of our patients? Like, I can't analyze the whole population this way. And then of course, availability. So what that means is like sitting down and designing what data you want to enter into CST, so that you can support not only point of care, bedside care, but also learning health systems. And a lot of clinicians aren't used to thinking about that. So when you say, you know what, we're going to record this element during our clinical documentation. We want to know whether this individual has missed any days of school since the last visit because of diabetes. Well, diabetes educators, clinicians, they might have a tendency to skip over that question if they don't think it's important for what they need to accomplish today. Unless you tell them, you know what, there's actually a national organization that we're reporting quality measures to, and that measure is very important for that. So they have to understand the mission, and that maybe not everything is about the point of care that you're providing today, but about making our care better overall. The role of care process design. You know, which objective data are recorded? How do we design provider documentation to support the extraction? Again, you know, this is what I just said. Like, it's not just about bedside care, but it's also about how we learn to improve population health. I've got just a couple minutes left here. I'm going to just give you sort of a quick T1D exchange example. We have mapped data from our CERNER electronic health record into a dashboard like this. This sits outside of CERNER. It's in our own population health software that we've written. But every day I can get into this and I can see these are T1D exchange, learning health network mapped metrics. We're following all the definitions that they use. And our clinical care team can pull up this dashboard any day of the week and they can see how we're doing. We can also segment the population in a variety of ways, just a few of which you can see on the right, the ones that I could fit on the screen. These are really important because they help us see whether the interventions we're engaged in to try to increase the number of patients using continuous glucose monitoring, or to try to increase the number of patients on a blood glucose meter who are checking glucose 4 more times a day. How are we doing on those, right? Are we moving the needle? And we have some longitudinal views as well, run charts. Here, this is really important for our national quality reporting. How many of our patients are achieving their A1C target of 7 or below? How many are in the range of 7 to 7.5, 7.5 to 9, and so forth. So we can see this longitudinally now. We don't even have to think about how to get this information out of CERNER. These are just running automatically every time we have a meeting with hospital executives, every time we have a meeting on US News and World Report reporting, or the T1D exchange quality reporting. We can just pull this up and it's immediately available to anybody on our team. And then optimizing the EMR for learning health networks. You have to think about how to change clinician and healthcare professional behavior to get the data in that you want. It's not enough just to have the data standards and have the reports out. If you want those data to be of high quality, then you have to monitor the quality of the data going in. And so in terms of designing documentation that matters, I'll give you one example. This is evidence-based. My colleague Joyce Lee published on 6 pediatric self-management habits that are commonly documented in electronic health records and how they associate with glycemic outcomes in diabetes. We were able to pull these into a population health dashboard. The 6 different habits that are described in this paper relate to insulin dosing, glucose monitoring, and problem solving. We can see how many patients are engaged or not engaged in each habit. And then we can count habits for each patient at each encounter, and we can see what the distribution is for their engagement with these 6 habits. I don't have it on here, but we even discovered a 7th habit that we're going to publish on soon that relates to healthy eating that associates with A1C health. I'm going to, because I know we have some other speakers, I'm going to kind of stop there. I do have some views. I'll share the slides. I'm happy to pass the slides out, just what some of our CERNER views look like. So I'll skip through some of that and just end with, I also talk about power plans. And I'm going to end with the fact that we are also thinking about how to pull external data together in this. And so we've partnered with Stanford University. We have a whole bunch of work that we've done on pulling in continuous glucose monitor data, insulin pump data into these population health reports. And now we can lay the EHR data side by side with these external data. You can do the same thing with patient-reported outcomes data from a third-party service, et cetera. And that's what you really want. You want your population health reports to include everything, whether it's internal or external to the EHR. So I'll stop there and let others speak. And thank you for your time.
Thank you so much.
Yep.
Tibor, do you have a quick question?
Yeah. So learning health system is improving healthcare, but it's also trying to have an impact on cost, or like. So my question is did you work with any health economists to try and quantify?
We are right now. We're working with Mathematica, actually, and this is as a part of our Rising Tide Alliance initiative to understand specifically the impact of remote patient monitoring on healthcare costs relative to our current standard model. We're also working with our accountable care organization called the Integrated Care Services. So in the U.S., everything's fee for service, but we have some value-based care organizations. This one is one of those, and they're tracking. They have access to all of the public and private payer insurance data and the cost data. So they're tracking information that we're pulling into this so that we can understand how costs change over time.
Thank you.
Thank you. Just be mindful of the time. So our second part is a panel discussion, and some panelists will join us online. And I will let my colleague Dustin take over this part.
Thanks, Sally, and thank you so much for that excellent presentation, Mark. Some of the key points that came out, I like how you said at the beginning, persistence pays off, but it does seem like research funding also plays a part in moving things forward and being able to shift the dialogue for your own work a bit. We do have a group of panelists now. I want to encourage everyone to keep writing questions in the chat. We'll get to some audience questions at the end. And thank you, Dr. Alain Gagnon, who's also online and not an official panelist, but has been doing a great job answering questions. But first, I'd like to welcome Dr. Angel Arnaout, who is the Chief Medical Informatics Officer at Provincial Health Services Authority, or Services Agency in BC. She has recently joined the organization coming from Ontario Institute of Cancer Research. We also have Dr. Jonathan Simkin, who is the Scientific Director of the BC Cancer Registry and co-chair of the Canadian Council of Cancer Registry, who will talk a bit about his novel work on implementing technology in the BC Cancer Registry to make better use of that data. And then finally, Dr. Danya Fox, who is an investigator and pediatric endocrinologist who has two pathways of research currently, one focusing on using survey data to better understand the challenges and barriers faced by children with type 1 diabetes, but also using data to evaluate and improve the quality of care that gender diverse children and youth are experiencing in BC. So before we get to more questions from the audience, I wanted to give each of our panelists a moment to speak and present on their own work. We'll start with Dr. Simkin. So please go ahead, John. I know you're in the room.
Sure, great. So grateful to be here. A lot of new faces, some familiar as well. I'm at BC Cancer and PHSA, so I don't make it around here too much, but it's great to see all of you and meet you. So traditionally, I trained as an epidemiologist. I worked in Whitehorse, government of Yukon for a number of years, working as a cancer epidemiologist, working on the cancer registry, with the cancer registry data there, doing population health reporting. So my lens is very population health based. I've never really worked in the clinic at all, but working in data analytics at the population health level. Then moved down here, Vancouver, BC, working at BC Cancer, and as well as the Data Analytics Reporting Evaluation Unit at PHSA. as the scientific director of the BC Cancer Registry. So the Cancer Registry is a population-based data set of all reportable tumors among BC residents. And that data is used for cancer surveillance, medical research, as well as supporting operational pieces for cancer hospitals and much more, supporting like screening programs, et cetera, with outcomes. Part of the cancer registry world is taking electronic, or traditionally not even electronic. We're 50 years since we've been population-based, and we have history since 1930s. But since 1970, population-based, and we had a whole team of cancer coding specialists who'd go into the charts, paper charts, collect that data in the form of reading up diagnoses and particular information about diagnoses and coding that to the ICD-03, which is the oncology 3rd edition classification, and putting that into a data set population-based, and then we can use that for surveillance, research, etc. Over time, with the introduction of electronic means of data, we have either enhanced linkages, but at this point, actually receiving real-time reports as they're generated to then integrate into our coding process and then the registry itself. So that's been where we really embarked on this. How do we leverage all this kind of electronic formats of data to code data faster? One of the biggest challenges for cancer registries in Canada, US, around the world is we're 2 years behind real time. So that really limits the usefulness of that data. A lot of people actually go to other sources to proxy what a cancer diagnosis population will be, maybe pharmacy data, which is real time, and RT data, which is all real time for us. But I mean, the cancer registry's function is, a disease registry population based to use that as a source of truth. So there's a huge push because of the demand of data to be more timely to essentially speed up the coding process. Now, what's also very difficult is there's not many people going into health abstraction for a niche area like cancer in this workforce. So we're seeing a lot more people retiring who have this very specialized skill set than people coming in. So that's been very difficult. And then training as well takes approximately 1 to 2 years in Canada. So if you do get someone in, it takes a long time until they're proficient in coding. So big problem. We are turning more towards machine learning and natural language processing specifically to, now that we have access to electronic and digital reports, to pick up some of these data that are in the reports and code them faster. So that whole process has been very exciting, very fun, very dynamic as technologies, especially in NLP, advance. And so we work with both pre-trained language models, either large language models, mostly generally not large, like one is BERT, which was introduced by Google in 2019. And there's variants of it like BioBERT, Clinical BERT, PubMed BERT. These are language models that have an understanding of language, and that's the most simplistic way of saying it, but have seen millions and millions of texts from the internet, have been fine-tuned to clinical notes, etc., that they can recognize relationships between certain terms, and you can train them to pick up certain patterns in, for example, for us, pathology reports, and code them to certain classifications. So that's where we've been, and we have developed various models to code certain pieces of data. We're certainly advancing our timeliness. We're working in orchestration methods, building pipelines to implement those and deploy those within an operational setting. So that's been super exciting. And our goal in the next year is actually to train and build our own large language model with the data that we have. So I think that'll be very exciting. But that's a bit about me. Thanks.
Thanks, Jonathan. It is really incredible the work that's happening at BC Cancer to leverage this technology. And I think what you spoke to echoes a bit of what Mark was talking about. To establish the learning health system, you need timely access to the data, but it also has to be in a format that's useful for the activity that you need it to perform. And so the EHR data isn't necessarily collected in a way that is going to meet the needs of all questions that we have for it. And so leveraging some of that technology may make it more effective and efficient. Before we move on to the next speaker, I just wanted to give Mark a moment if you wanted to reflect on that. And are you using any of these advanced technologies in the system that you've set up at Mercy Children's around NLP or large language models or anything like that?
Yeah, so some of our first models, so we had different application for machine learning and deep learning models. So we built a couple of deep learning models initially that were using natural language processing from all the free text clinical notes. And these models for forecasting were very large. They were recurrent neural networks. And we were very excited about their performance, but we also recognized that we might be overdoing it a bit, and that there are criticisms around overfitting when you're trying to forecast or classify if you're using a wide model like that. We weren't too concerned about that because we can retrain the model as the population characteristics shift. So I don't think that wide models are always a bad thing, and it's not truly overfitting, but just wide models can be fine as long as you have the appropriate processes in place. But we had a goal of disseminating to many diabetes centers, and we recognized that explainable AI, clinician trust in our models, trust in themselves to be able to implement models that we create with their own data was probably going to be an issue if we presented them a model with over 100 features. So we kind of pivoted away from natural language processing, and we started working on more parsimonious models that could compete with the original models we created. We used those as the bar, and we were able to create models that use about 15 features that are all from discrete data in the medical record. So we started with natural language processing. We moved away from it. We're probably going to get back to it. I think in the diabetes space, the place I'm most interested in large language models is actually in content generation. So how can we deliver diabetes education or behavioral content to families using large language models? The other application I'll mention is, I mentioned to somebody earlier, the PCARN network, Pediatric Emergency Medicine. When we talk about all the data transfer agreements and the barriers to getting those signed, PCARN has worked with a third-party vendor. I don't remember the name of the vendor, but they're using natural language processing, and they are actually using it to identify patient identifiers in free text notes and to scrub those so that they can bring them all into a common repository. And they've been able to convince all these pediatric health systems in the US to participate in that. It's very, very hard, right? When you're talking about the risk of sending PHI where it shouldn't be sent, but they have very reliable approaches to that.
Thanks, Mark. Before we move on to other questions, Danya, would you like to introduce yourself and talk a bit about what you've done with REDCAP and the EHR?
Sure. I'm Danya Fox. I'm a pediatric endocrinologist here at BC Children's. My project that they asked me to speak about today was started a few years ago as a quality improvement project to help reduce our wait times for our gender clinic. We had seen like exponential growth in our referral volumes year by year, and we just didn't have the resources to manage all of our referrals. So we had designed these new style of appointments that were really just kind of brief intakes with our nurse and social worker to help families kind of just on those initial steps until they could later on meet with the physician. What was meant to be this kind of early meet and greet and support, also, of course, our wait time started growing, and we found that on average, families were waiting close to 7 months, often, and a large, obviously, a portion longer than that, which we felt was unacceptable. So started a multi-pronged project to try and get our wait times down, with our goal being 3 months for 80% of our patients. And a big part of that was developing a REDCAP intake questionnaire for all of the new families referred to our clinic. Actually modeled after mental health was where we got the idea, which some people may be familiar with. We designed our own just because there was obviously very specific questions we needed to ask. Did use some parts of validated surveys, but a lot of it was what our care team needed to know. And then one of the things we did was we had advisory councils of parents and caregivers, older youth and younger youth, and then worked heavily with them to adapt our surveys to make sure that the questions were asked in appropriate ways, people would feel comfortable answering them, that sort of thing. So it was quite a long process. We also avoid questions like suicide for the same reasons as you. There are certain things we say for the clinical encounter from a safety perspective. Similarly, lots of reminders that go out over time. We've probably sent almost 500 surveys now. Our response rate is about 80%, which I'm quite happy with. I'm hoping we can get it up a little bit higher. We are using QI/QA REDCAP, so we can't send text messages yet, but we're hoping that that may change, just especially, so we designed it that there's, although they're linked, it's a completely separate survey for the youth that goes out, just because of the sensitivity of the content. We wanted people to, like the youth, to feel comfortable that there was no way the parents could see their data, which also helps us kind of understand, because it's an area where often there is a discrepancy between what the parents feel about the situation and what the youth feels. So we're really hoping to get SMS invites going to improve our response rate for our teenagers. But yeah, I mean, we've been gathering feedback as we go, and kind of we're going to do like our next iteration and kind of make some changes to the survey. And then our goal is that then everyone at the end will be asked if they'll be willing to share their data for research purposes, at which point the data would be transferred over to Research REDCAP, and then would be inviting people to further surveys over time to be able to look at kind of longitudinally how their care is evolving.
And you've had great success with this program, which is, and gotten your wait list down quite significantly, which is a real win, and I think something you should be congratulated for.
Yeah, actually, well, sorry, Beth, I forgot.
No, go ahead.
And that it looks like we're still collecting data, and we're hopefully going to be presenting it soon. Our actual time for the visit has gone down by 10 minutes. But the biggest thing for us is that it used to be our nurses and social workers always wanted to do the visits together. And we have finally shifted that they do them on their own. And I think part of it is that we say, you know, if you get the intake, it looks really complex, they will pull in a colleague. And usually there's enough people around that, you know, kind of a couple days before you can say, hey, this is a complex family. I think this warrants a nurse and a social worker. So most of the visits are happening with just one provider, but then they have that ability. And so effectively, we've been able to double our number of visits just by getting people to feel comfortable doing it as a solo visit.
And what's the trigger? What defines a complex family?
It's up to the team, really. Like, I think if, you know, sometimes if we see that a family maybe, like, the parents are really not on board yet, the youth is in a totally different place, sometimes having two different providers, being able to talk to them independently. If there's, you know, so I think like a lot of mental health issues, that sort of thing. So it's really up to the team to decide. We leave it to their discretion. But they're pretty judicious with it, it seems like.
And are there, I don't know this, and I'm embarrassed to say I don't know this as a pediatric endocrinologist, are there validated surveys? Yeah, I didn't think there were. So that seems like a ripe opportunity as you're doing this work. If you can think about how to add test surveys or test questions, if you could also bake, so we, one of the missions for my talk today was to kind of also talk about breaking down the barriers between research and quality improvement. Is there quality improving care? If you have an eye toward research questions that need to be answered in the future, at least in the US, there are two approaches. One is for me to design a study prospectively and say, you know what, I want to develop a new survey that addresses, you know, a psychosocial domain. And so I need to follow the process for validating surveys. And I'm going to recruit people into the study. I'm going to do this. The other is, look, we've got some very practical needs. We have to ask families certain questions right now, but some of these questions could also be valid at addressing certain psychosocial domains. And since I'm already implementing them in clinical care because I have an operational need to do it, I could retrospectively go back and study that if the families have given me permission to use the data. And so just think about the design of how would you go back and do the validation for some of these questions in the future. And maybe it does require a prospective portion to a study, but initially you can do some external validation by looking at the relationship between different factors in the survey and clinical outcomes. And then maybe you have to go back and you have to do some additional prospective work for like internal validation.
Just a quick comment on that. Probably 5 years from now, or probably longer, these two fields are going to collapse, like quality improvement and research. Like, to keep this separate doesn't make sense in the long term.
Well, the other thing, you know, for people to keep in mind is that quality improvement came out of industry, right? It came out, I mean, originally out of Toyota, right?
Yeah, I am.
And so you've got Lean, Six Sigma, and sort of the whole model for improvement comes out of industry, and it evolved with its own vocabulary, its own vernacular, and its own set of statistical process control methodologies. But in parallel, in the psychosocial, right, the behavioral and the organizational behavioral research worlds, the field of dissemination and implementation science evolved. And remarkably, these two fields have had convergent evolution. They still have their own vocabularies, their own vernaculars, their own statistical methodologies that are the favorites, but they are, I would say, meeting the 80-20 rule in terms of 80% overlap, 20% difference. And there are advantages and disadvantages of each one as a model when you're trying to accomplish a particular thing. But I think that D&I research has already demonstrated that, you know, that sort of the difference collapses, because as soon as you move from the QI vernacular to the D&I vernacular, you realize, oh, all of these behavioral and care delivery interventions that are dying on the vine out there after getting funding, you know, and great clinical trials with great outcomes, they're dying because nobody's funding and nobody's pursuing the important adaptation of those into new care settings or with new populations to give them staying power and survivability. And that's where we really need to double down our investment if we want all the great research we've been investing in for decades to actually make a difference at the point of care. You know, so I would encourage everybody to become a student of D&I research. It's not easy. There are 170 theories, models, and frameworks that underlie it. So you better put on a pot of coffee and enjoy some late night reading.
Thanks, Mark. We do have a hard stop at noon, and I apologize to everyone for that, because I think we could have this conversation for a very, very long time. But I wanted to make sure Angel also had some time to reflect from the PHSA perspective on where we're going. You mentioned your instance of CERNER started in 2008. You've had this significant amount of time to mature it and develop these processes to allow this work to happen. And as we're somewhat new in our organization and still maturing, I really wanted, Angel, your reflections on what are the priorities moving forward and how you see things evolving here, like Tibor said, in the next 5 years to better enable the learning health system and that continuation of research and quality improvement.
Thanks so much.
Andrew, you mute yourself.
Sally, you need to mute your computer.
Yeah. Can you hear me okay? Okay, there's a lot of echoing. Maybe it's okay now?
Yeah.
Okay. All right. So, hi everyone. Nice to meet you all. As Beth mentioned, I'm new here. It's my 4th month. My background is I've been a surgical oncologist for 15 years. When the pandemic happened, I was very free because I had no access to the operating room. I went to Kaiser to learn about how digital tools can be used to triage patient care and how patient-reported outcomes can be used to design how we structure clinics in cancer. And then I went to Stanford last year and worked with the informatics team, including those at Stanford Children's Hospital, probably what you were referring to earlier, Mark, with David Schenker on how to incorporate diabetes tools into the patient clinical record. So just being here for 4 months, I have made it my sole purpose for existing over the next 6 months to make data accessible to all the wonderful providers and clinicians here at BC, not just PHSA, but across the VBP enterprise. The reality is that, you know, I think there are a lot of things that have been built into CERNER or designed by the CERNER team starting 10 years ago that did not make the process very data accessible or friendly for the clinicians. The priorities that I have, and hopefully it'll take less than 5 years, is really to democratize the data and make access to clinicians a whole bunch of self-serve tools. We do have the OMOP data model, which has already been built at PHSA, which we will make available along with some educational programs, data literacy training, self-serve analytics tools with website training available to clinicians so that they can actually use the data, not just for detailed analytic purposes, but for checking out a hunch, for hypothesis testing, for defining a QI initiative. My background is not just in surgery, but I also have D&I, or as we call it, knowledge translation, implementation science research, physician practice change, quality improvement on a national level. So I fully understand the pain that our providers are going through when you're not able to touch the data that you put in yourself. We've defined a couple of use cases for the data that which will be associated with varying grades of data access. Clinicians want to use data for QI, of course, operations, business management, but also point of care delivery. When I was at Stanford, you were able to see a patient in front of you if you didn't know how to treat them because they were presenting with an unusual presentation of symptoms, for example, and you were deciding between 2 different treatment options. They didn't necessarily fit what the clinical trial patient cohort looked like for guidelines. You can actually interrogate the EMR yourself, and it'll come up with a solution for you based on your own population and your own local institution, what the outcomes are. And so clinicians need to be able to access data for point of care purposes, as well as for research. And so research, we talked about earlier, research blending in with QI, but when I talk about research, it's more about linking with provincial data sets, doing questions that look at the science of academic medicine as opposed to the delivery part. To answer questions about delivery, it's probably more about QI, but to answer questions about the science of medicine, that's what I define as research. And so that's where you might benefit from provincial data sets that we are lucky at PHSA to have access to, as opposed to the other health authorities. And so trying to create this sort of graded level of data access, including self-serve tools, all the way to advanced analytic tools if you did need the data analytics team, trying to offload some of the work that they're doing so that the wait list gets shorter. Right now, it's painful for any clinician to access data. It all goes through the data analytics team, which takes somewhere around 6 months to 2 years to get a response. That is unacceptable. And so we're trying to limit their work only to the ones which require advanced data analytics, and then provide a whole bunch of self-serve tools with data literacy training for the average provider need. There has been a couple of different moving targets lately to try and get this work done, but it is, as I said, my sole purpose for existing for the next 6 months to try and provide this rectified solution for you all. So my question is to Mark. One day I will probably come visit you. I need to understand how you've integrated REDCAP with CERNER, because right now the CERNER team is a huge team with very slow moving activities when it comes to incorporating new tools into CERNER. And so that is another thing that I need to figure out. Maybe we could talk offline about how to do that. There are lots of people with REDCAP data sets. The integration with CERNER is not good. So yeah, need to figure that one out. But yeah, more to come, and hope to keep everybody updated so that the world of data access becomes brighter. Thank you.
Thanks, Angel. I have many, many more questions, but unfortunately we have to vacate the room. If anyone wants to stay online and has a burning question for Angel, you're welcome to do that. But I know our guests in the boardroom have to leave. So I just wanted to say before we end a really quick thank you to Mark again for that presentation. You give such a great example of where we could go and what's possible, and that